So let's get started. And first of all, I'd like to thank Diabetes India for really inviting me to participate in this event. It's a great honor, and I'll just get started. So the title of this talk is there a current role for sulfonylureas in diabetes management? So I thought I would start with this slide first. And this is really just a reflection, thinking about the evolution of therapies in diabetes in recent years. And I wanted to just highlight that really we've had sulfonylureas since before the 1950s at least. And really we've used them much longer than any of these newer agents. In fact, their safety profile and their efficacy is now well established. But I just wanted to highlight that to you. While I was training in endocrinology, really, we only had, insulin, sulfonylureas, metformin. We had very few agents. And really all these newer agents have appeared after the 1990s. So as I've mentioned, really, we've had extensive use of the sulfonylureas in the treatment of diabetes since the 1950s. And they've become a mainstay of treatment, either in monotherapy or in combination. And on this table, I'm showing you the main agents that have been used or are currently available. And you can see that we have several generations of sulfonylureas, the first, second, and third generations. And I'm also showing on this table the duration of action, the time to peak, the excretion in the majority of cases, which is renal, and then the use in patients with renal dysfunction. With the earlier sulfonylureas, there needed to be some adjustment or you had to avoid them. But with the newer generations, really, there's no dose adjustment needed. So it's just to basically show that really we've had them around for a very long time. And I would say that we're still using a lot of the second generation agents, and really a lot of the newer third generation agents are now becoming available in generic form. So let me just go through briefly the mechanism of action, which I'm sure you're all aware of. So we know that really the sulfonylureas stimulate insulin secretion from the beta cells in a non-glucose dependent manner. We know that as the sulfonylurea binds to the sulfonylurea receptor on the beta cell in this case, and this is shown on the diagram on the right-hand side, and you can see it's the left box. When the sulfonylurea binds to its receptor, which in this case is SIR1, there is closing of the potassium ATP channels, and this inhibits the efflux of potassium ions through these channels and results in membrane depolarization. As there is membrane depolarization, this results in opening of voltage-sensitive calcium channels and allows the influx of calcium ions. As the calcium concentration inside the pancreatic beta cell increases, there is an exocytosis of insulin-containing granules. All of this we learned in medical school. But I like this particular diagram because it shows us clearly that sulfonylureas may have effects on other tissues as well, which carry these potassium ATP channels. And in particular, we're worried about the heart when we consider the use of sulfonylureas. The myocytes contain the SIR2A receptor, and really the main concern is that sulfonylureas may inhibit ischemic preconditioning. Let me just go through what ischemic preconditioning is and why it's important in the heart. So we know that ischemic preconditioning occurs when the cardiac potassium ATP channels open automatically during brief episodes of mild myocardial ischemia. You can see on the left-hand side, here we have no ischemic preconditioning. And what happens when you don't have this is that there is prolonged occlusion of a major coronary artery, and we may get a large myocardial infarction. When ischemic preconditioning is permitted, with repeated and brief occlusion of the same vessel, this preconditions the myocardium such that subsequent prolonged occlusion leads to a smaller infarction. So drugs that can inhibit these potassium ATP channels, such as sulfonylureas, may actually inhibit this process. And you can see this in the diagram on the right. Certain sulfonylureas, and this is the worry, may abolish ischemic preconditioning, resulting in risk of a large infarction size. So this table has come from a recent work, well, from 2015 of Sanjay Kalra and his team. And I just wanted to highlight this idea of ischemic preconditioning, and that, as I've already mentioned, sulfonylureas may increase the risk of losing this. However, we have to take into account that it's not all the sulfonylureas. Gliclazide, for example, does not interfere with nicorandil activity and does not interfere with ischemic preconditioning. Glimepiride as well suppresses ventricular tachycardia and lowers blood pressure and induces ischemic preconditioning. There are also other pleiotropic events or effects of sulfonylureas. So I've just talked about the mechanism, I've talked about the risks with respect to the heart, but there are advantages such as antioxidative properties, angiogenesis, and also vascular health as well. But let's talk about really the role of sulfonylureas in diabetes. So I'm just going to summarize some of the data on the glucose lowering efficacy. So this table really is comparing, as much as we can, the degree of glycated hemoglobin reduction with the major classes of hypoglycemic agents. Direct comparisons are lacking, but meta-analysis of placebo-controlled trials does show that the mean reductions may be quite similar between GLP-1 receptor agonists, SGLT2 inhibitors, and sulfonylureas. But you can see that really sulfonylureas have consistently shown, I think, quite significant glucose lowering effect. On this table, I'm showing you meta-analysis data of randomized controlled trials. And here on this table, we're looking at the reduction in glycated hemoglobin. There's also data on risk of hypoglycemia. But I just wanted to show you a couple of these studies. For example, the Hearst meta-analysis, again, looks at 31 studies, and we can see that the reduction in glycated hemoglobin is roughly 1.51 or 1.62 with the sulfonylurea versus a comparator. If we look at the other study that I've highlighted, again, 27 treatment comparisons, and we can see here again, there is with sulfonylureas a reduction of 0.79, DPP-4 inhibitors, again, 0.79, and GLP-1 receptor agonists, 0.99. So the idea of showing you this is not so much to compare one agent to another, it's really just to show you these agents are very effective in lowering blood glucose. They may be as effective as, for example, some of the newer agents that we are currently using. And finally, I wanted to show you the classic trials that we have. And of course, we can't really avoid talking about the UK PDS study. And here again, remember the intensive arm was really sulfonylurea, chlorpropamide or glibenclamide or insulin versus conventional treatment. And if we look at the glycemic efficacy at 6 months and long term, we're getting reductions to 7% or 7.9%. And this was associated with a 12% lower risk of any diabetes-related endpoint. The advanced study, another older study, looking at intensive treatment versus standard treatment, again shows this glucose-lowering efficacy. And again, the incidence of complications decreased. But let me just highlight 2 additional studies which look specifically at long-term complications in diabetes. So we have the analysis of the advanced study, which is the advance-on study. This was a post-observational follow-up from advance, and again, looking at intensive versus standard therapy. And here you can see with respect to glycemic efficacy, we had glycated hemoglobin levels maintained over 10 years. And this persistent benefit showed really benefits with respect to end-stage renal disease. If we look at the VADT study, here we have the follow-on study of intensive versus standard care. And again, the reduction in glycated hemoglobin, 6.9% versus 8.4 at 6 months. And long-term, really, the difference was not significant. However, long-term follow-up, again, showed significantly lower risk of major CV events with intensive therapy. So it's just really to highlight that this significant glucose lowering effect is also related in the long term, in many cases, to benefits with respect to micro and macrovascular complications. But let's turn our attention as well to durability. And really, the evidence we have from here is from the ADOPT study. Remember, this again was a study comparing the effects of rosiglitazone, metformin, or glyburide. And I'm just showing you on the right-hand side, here is the difference in glycated hemoglobin, or the change in glycated hemoglobin during the 5 years of the study. And you can see that really glibenclamide, or glyburide in this case, was really the least durable. And in fact, monotherapy with sulfonylurea was durable for only 2.75 years, and for up to 4 years in 67%. But you can see by the two graphs, the graph on the left shows you the incidence of monotherapy failure, and you can see that this is significant with glyburide. So I've shown you now really the data on glycemic efficacy. I think it is important. We can see why we keep using these drugs, and I've shown you the durability aspect as well, that maybe at least compared to, in this case, aglitazone and metformin, the sulfonylurea was not as durable. But let's turn our attention to weight gain. As you all know, this is another concern with the use of this class of agents. And I've only got one slide here. The weight gain observed with sulfonylureas may be explained by the insulinotropic actions, the reduction in glycosuria, increased caloric intake to prevent or treat hypoglycemia. In fact, in the UK PDS, patients on sulfonylurea monotherapy gained more weight compared to dietary intervention, and you can see the figures here. However, the sulfonylurea-induced weight gain stabilized after the first 3 to 4 years, whilst insulin had progressive gain. So I think this is another aspect of sulfonylureas. Yes, you will get a little weight gain, but it doesn't keep increasing. It tends to stabilize. In another study, initial treatment with glimepiride was associated with a significantly greater decrease in body weight than with glibenclamide, while providing equivalent glycemic control. So here I'm just highlighting that, yes, we may expect weight gain. However, certain sulfonylureas are associated with a lower incidence of weight gain, in particular glimepiride. So we can think of glimepiride and maybe also gliclazide and glipizide to be associated with less weight gain than the older generation sulfonylureas. The real-world evidence, just to show you a little bit more information, and this is the only other slide on weight gain, we have from the Zodiac study. Now, if you look, this was almost 30,000 patients with type 2 diabetes, and the idea was to look specifically at change in body weight with sulfonylureas added on to metformin therapy. I just want to show you the main findings. Again, non-significant linear change in body weight during follow-up, and a non-significant difference in body weight between sulfonylurea add-on combinations. But we can see there is a difference in the change in weight after 5 years. Here, 3.9 kilograms for gliclazide, 3.3 for glibenclamide, 0.1 for glimepiride, and 1.4 for tolbutamide. Again, supporting this idea that certain sulfonylureas, in particular glimepiride, are associated with a lower risk of weight gain. Let's turn our attention to hypoglycemia, another effect of sulfonylureas that we may be concerned of. So I'm just showing you this table, which really summarizes the randomized controlled trials in which we're comparing a sulfonylurea either with another sulfonylurea or with another treatment. And you can clearly see, in general, for example, look at the advanced study, gliclazide versus standard control, there is an increase in the rate of severe hypoglycemia. However, remember, severe hypoglycemia, yes, we are worried about it because it is associated with increased mortality, but this is probably not a causal relationship. Hypoglycemia is probably a marker for illness severity. In the Carolina study, if you remember, and I'll go into this in further detail, remember in a high-risk population, the risk for MACE was similar between both arms. So even though the hyper rate was greater with glimepiride, this does not translate into a greater mortality risk. And if we look specifically at a couple of the studies shown on this table, for example, let me just go back to the UK PDS. Here, the risk of hypoglycemia was 0.12 per person year with the sulfonylureas, and this was much lower than the rate with insulin. But let me just remind you of the GUIDE study. Now, here it's shown on this table, and we can see here the treatment comparisons were gliclazide MR versus glimepiride. You can see that in this study, there was significantly lower confirmed hypoglycemia with gliclazide versus glimepiride, but you can see that the rates of severe hypoglycemia were no different in either arm. So it's just to highlight that, yes, we do worry about hypoglycemia, but remember, hypoglycemia may be a marker of disease morbidity. But there are studies that have shown that really, even though we may get greater rates of hypoglycemia, they're not related to an increased risk. And again, this table, it does show that there is a greater risk, but it's not that high if we're thinking about the rates in real world. Let me show you the real world evidence as well. And again, there's this study by Holstein. This is a meta-analysis of real world data. And we can see here that the episodes are quite low. Obviously higher with the sulfonylurea as expected, but it's 5.6 episodes per 1,000 person years. And this is with glibenclamide. If we turn our attention to the Van Dalen study, here again, 120,000 new users of anti-diabetic drugs, duration almost 4 years. And yes, there was an increased risk of hypoglycemic events in existing sulfonylurea users compared with metformin, but this was really associated with a GFR less than 30 in a lot of the cases. So yes, hypoglycemia is something that we do worry about. Certain sulfonylureas may have a slightly lower risk of hypoglycemia, maybe the newer generations more than the older generations, but in general, the rates in a lot of the cases are not as high as we may believe. So let's now turn our attention to the CV outcome studies. Now, let me give you a brief history about one of the most famous studies that really brought attention to this possible CV risk. And it's associated with this mechanism that I showed you right at the beginning of the talk with the loss of ischemic preconditioning. So this is the University Diabetes Group program, and this study included 823 persons, tolbutamide versus insulin versus diet. This study was carried out in the 1970s. And here they found that in the tolbutamide arm, as you can see with the curves, there was an excess of cardiovascular deaths versus placebo. However, we have to remember that this study did have methodological issues. There was variable cardiovascular risk at baseline. It wasn't carried out as the current CVOTs are carried out. There was also a small number of events, so we can argue that it was underpowered. And also there was no real formal assessment of CV death. There was no adjudicating body as we have nowadays. But as a result of this study, there was an FDA black box warning for CV mortality with sulfonylureas, and tolbutamide itself was withdrawn. But things have changed. So let me just show you that really the CV outcome data with sulfonylureas is quite controversial. Meta-analysis of randomized controlled trials show really neutral outcomes, whereas observational studies show variable but increased cardiovascular risk with sulfonylureas. So this is where the controversy is. No? When you actually do a meta-analysis with all the studies that are randomized controlled, they don't find a risk. But when we look at a lot of the observational studies, there is an increased risk. But there are drawbacks with this. For example, individual randomized controlled trials are limited by lack of high-risk patients at baseline, low event rates, and short study duration. Whereas if we're looking at observational studies, despite their large numbers, they suffer from selection bias, information bias, and residual confounding. And on this table, I'm just showing you a couple of the most famous studies that have included sulfonylureas and evaluated cardiovascular outcomes. So we have the ADVANCE study. Remember, this was intensive control versus standard control. And I'm showing you here the rates or the incidence of the CV outcomes. And we can see that really there was the cumulative incidence, let me just read that, of CV death, MI, stroke with a hazard ratio of 0.94. Not significant, but not really showing risk. If we look, and there was a significant decrease in microvascular and macrovascular events, but a non-significant decrease in major macrovascular events. If we look at the TOSCA study, now this was also a very interesting study. Again, this is patients with type 2 diabetes, and we're looking at add-on treatment with pioglitazone or add-on with sulfonylureas, and we can see there were 3 sulfonylureas included. And what was evaluated was the first occurrence of all-cause death, non-fatal MI, non-fatal stroke, or urgent revascularization. And we can see here, again, we've got a hazard ratio of 0.96, a P that is not significant. So really, we're not finding any difference between the 2 arms with respect to the primary endpoint. So again, there is data that is showing neutral outcomes. These are randomized controlled trials, but observational data does seem to show increased risk. However, I think what has helped us come to some kind of conclusion regarding sulfonylureas is the Carolina study. I'm sure you're all aware of this study. This was a cardiovascular outcome study, and the question here was, what is the effect of linagliptin compared with glimepiride with respect to MACE in patients with type 2 diabetes and elevated cardiovascular risk? And you can see this study included 6,000 patients follow-up of about 6 years or so. And we can see here the primary endpoint of 3-point MACE with a hazard ratio of 0.98 and with a P of 0.01 for non-inferiority, showing really non-inferiority of linagliptin versus glimepiride. But we can see here that the rates, and I've shown you on the table on the left, for MACE were 11.8 versus 12%. So really there was no difference between the arms. So the meaning of this study at that time was really showing that the use of linagliptin showed non-inferiority with respect to MACE compared to glimepiride. But it also showed us that glimepiride does not increase at least the risk for MACE in this particular population. If we look at the other outcomes, for example, hypoglycemia, you can see on the curve on the left, clearly there is a greater risk of hypoglycemia with glimepiride, the hazard ratio of 0.18 with a P that is highly significant. However, you can see from the table, while the rates of hypoglycemia were higher with glimepiride, it's important to note that the absolute risk of hypoglycemia was quite small, even in the sulfonylurea treated patients. And if we look at the risk for severe hypoglycemia, it's 0.3 with linagliptin versus 2.2 with glimepiride. It's still quite low, even though it is significantly different. And finally, I just want to show you the effects on mean change in glycated hemoglobin. Again, these favored glimepiride over linagliptin, but overall there was no significant difference between the groups. And you can see the levels during the whole study. They're very similar between both arms. If we look at weight gain as well, again, a modest weight gain with glimepiride, and this was maintained thereafter. Remember, I mentioned that with respect to weight, you may expect a certain weight gain, but this tends to be maintained. It doesn't really increase with continued use of the sulfonylurea. And finally, this recent systematic review and network meta-analysis of mortality risk with sulfonylureas does seem to suggest that there is a difference between the first, second, and third generation of these agents, with gliclazide really showing the lowest risk. And you can see that the last 3 are the really third generation sulfonylureas. So in summary, with the CV outcome data, it's still controversial. I think Carolina does reassure us a lot, but if we look at this kind of mortality risk data, it does suggest that the older generation drugs were associated with a greater risk. And finally, in the last part of the talk, I'm just going to talk about the guidelines. Why are there differences? And I think this is really where I can answer the question of this particular talk. So if we look at the recommendations for use of sulfonylureas in patients without atherosclerotic cardiovascular disease, there is a difference among guidelines. Australian, Indian, and the WHO guidelines specify sulfonylureas as second-line agents, whereas NICE and IDF include sulfonylureas as one of the preferred options along with DPP inhibitors and either pioglitazone or an SGLT2 inhibitor. But really, it's the ADA, EASD, and the European Society of Cardiology that place them in the fourth or fifth line. If we look specifically on this table, we can see here they say add SU as second-line agent only if cost is a compelling issue. They say reserve sulfonylureas for fourth-line treatment if there is a compelling need to minimize hypoglycemia or weight gain. But in general, if we look at the European guidelines, they actually say reserve sulfonylureas for fourth-line treatment. So why are there these differences? Let me just first of all just show you this evaluation of guidelines. And I think when we decide to use a particular guideline, it's important to know really what we are seeing or what is being assessed. So this is an old analysis from 2018, really, looking at the AGREE 2, which is the appraisal of guidelines for research and evaluation. We can here see that they compared the ADA guidelines of 215, the Canadian Society guidelines, also the NICE guidelines, and also the ACE guidelines. And we can see here that they give overall scores. Now, the ADA guidelines come out with a 50% overall score. And this is because it tends to be a consensus. The actual scientific rigor is given a very low percent, 28%. So though evidence-based, the recommendations are really the opinions of the authors. And this happened with the consensus statement in 2018. And in fact, if we look at really the Canadian guidelines and the NICE guidelines, they have a significant amount of scientific rigor, clarity of presentation, and also if we look at applicability and resource implications, these are also considered in the NICE guidelines. So just take this into account when you're looking at guidelines, that sometimes they're not as thorough as we would possibly want. So why are there differences among guidelines? So I've already mentioned that the ADA guidelines are only considering sulfonylureas if cost is a driving factor. I think they're not taking into account the other properties of this class of agents. If we look specifically at the EASD ADA and the ESC EASD recommendations, they suggest SGLT2 inhibitors and GLP-1 receptor agonists as second line based on the results of CVOTs. And they cite evidence from the observational trials for increased cardiovascular risk with sulfonylureas. However, remember, the majority of patients that we treat do not fulfill the inclusion criteria for CVOTs. So this also brings into question the generalizability of these results in a broader diabetic population. Remember as well, I've shown you the randomized control trial data, and that hasn't shown increased cardiovascular risk. It's been really the observational trials. So in my opinion, the weight of evidence does not show increased risk with this class of agent, and in particular with the newer third generation agents. As I've said, there may be differences among the individual agents. And finally, many times it's really only the NICE guidelines that take into account the cost-effective data, and they should perhaps be considered. So this is my final slide. Is there a current role for sulfonylureas in diabetic treatment? Of course there is. Remember, again, the EASD ADA consensus or recommendations do not provide recommendations for patients without compelling indications. So they're only considering hypos, weight, and cost for a particular drug class in their algorithm. And this is possibly the majority of patients. They may not have these issues. So really, we do need to look at sulfonylureas and assess them in a more honest and correct manner. Current evidence would suggest that in the absence of atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure, a later generation of sulfonylurea is still the most cost-effective second-line agent for these patients, especially in where we live, India, and myself in Mexico, but I think even in the first world setting. So I just want to end with this quote. This is probably why, despite the negative narrative towards sulfonylureas over recent years, they remain the most widely prescribed second-line agents, suggesting that practicing physicians know something that the consensus experts do not. Thank you very much for listening to me. That's my last slide.